Hi, everyone. We'll give everyone just a minute to get their audio connected before we go ahead and start. All right, good morning, everyone. Welcome to today's session of the Women Veterans Empowerment webinar series titled Don't Skip, Take Charge of Your Breast Health. We have great speakers lined up for today. We have Dr. Marianne Richmond from the Lewis Stokes Cleveland VA Medical Center, Rhonda Barber with GE Healthcare, Women's Health Initiative, and our very own Cheryl Vines, Director of Research and Education of Paralyzed Veterans of America. My name is Marissa, and before we start, I just want to cover a few housekeeping items. Today's webinar will be recorded and available to watch later on. As a webinar attendee, you'll see as you enter, you are muted, but if you have any questions, please feel free to use the Q&A box and we'll address them at the end. If you have any comments or technical issues, please use the chat box and let me know. And now I will hand it over to Cheryl to start. Thank you.
Thanks, Marissa. You can go to the, skip maybe the next two, to that slide, yes. So thank you, and on behalf of PVA and the Anita Bloom Committee, I welcome you this morning. I also applaud you for your interest in this very challenging topic that is of concern to many of us. Some of us don't even like to talk about it. So I'm glad that you're here. I'd also like to thank Rhonda Barber and her colleague, Cassie Ritchie, who have really been integral in putting this together. They're the ones that came up with our great topic of Don't Skip. And we're glad to be working with them on this important initiative. I'd also like to thank Dr. Marianne Richmond, the SCI chief at the Louis Stokes VA in Cleveland, who is having a little timing problem today. We're hoping that she's going to join us, but she's the one that actually is on the ground carrying out these activities. So my part today is to answer some of the tough questions, the questions that we hear from our members and other women who are veterans. Are women veterans more at risk? Are women with disabilities more at risk? And are you yourself more at risk? So my answers today are yes, yes, and I don't know. Can we go to the next slide, Marissa? So I'm not a military veteran, but I am a veteran in the war against breast cancer. I survived breast cancer quite a few years ago, and very honestly, a mammogram saved my life. I was a regular mammography person. I actually started having my mammograms when I was 33 years old, and that was because my mother had been diagnosed with breast cancer when she was 33. So I had many breast, it was a lot of work to talk people into letting a 33-year-old woman have a mammogram back in those days, but I was successful every single year. And the year that I turned 50, I went to have a mammogram. It was one of those days that, you know, I tried to put it off. I thought, you know, I can't go today, but for some reason I was like, I think I need to go. So I went and had a mammogram, and they found a very small, the doctor described it as the size of a, smaller than the size of a pea, breast cancer in my right breast. The breast cancer lesion was all the way against my chest wall. That means that by the time I felt it with my regular monthly breast exams, it would have been very large, and it probably would not have been as easily treated. So as I moved through my experience with breast cancer, many of my friends would call me and say, you know, what can we do for you? What can we do? And I told every single one of them, get a mammogram. I made my sister start she had not been a good mammogram person, and I made her start sending me the results of her mammogram every year, and I dunned her if she didn't. But I wanted everyone to get a mammogram. My friend Debbie, who you see pictured here, a dear friend that I had known for many years, held a master's in public health from the University of Illinois, worked for the State Department, the California Department of Health. She was a Paralympic athlete, very astute. When she called me and asked, what can I do? I said, get a mammogram. And she got really quiet. We were on the phone and I said, Deb, you've had a mammogram. Well, no, she hadn't had a mammogram. And when I asked her why, she said, it's really just the hassle factor. It was hard for her, as you can see in the picture. She had some limitations in her hand. She was tetraplegic. And she said, to get my shirt off when I'm not lying in bed is just such a hassle. And I won't be able to do some of the things they need for me to do. So I just haven't done it. I said, well, please, So not only, I'm sure it wasn't just me, but she did that year have a mammogram. And her mammogram showed that she had a very large cancerous tumor that had metastasized to other parts of her body. And she lived for about 2 more years, undergoing lots and lots of treatment. But I always felt bad that I didn't think about telling my friends before I had my own experience that that you needed to have a mammogram. So I've redoubled my efforts working with Centers for Disease Control and other public health groups on this very important issue. Could we go to the next slide? So are women veterans at greater risk for breast cancer? And we're not sure about that. The challenges in terms of the studies that we've been doing in terms of actually looking at numbers of cases, because the number of women veterans has increased so significantly over the last 20 years, it's difficult for them to tell. More people are getting, it was difficult to tell women veterans when most women veterans were getting their health care, their breast health and their, women's health care outside the VA. Now that more people are getting their health care inside the VA, it's a little bit easier to be able to put some numbers to that. What we do know is a 2009 military study did show that breast cancer was the third leading cause of cancer in individuals who were in the military, not veterans, but people that were actually active in the military, behind testicular cancer and prostate cancer. So, considering that, and we all know men can have breast cancer too, but the highest incidence is actually in women. Let's go to the next slide, please. So Dr. Sarah Colonna and her colleagues at the University of Utah went back and did what we call a retrospective study. They went back in like 2015 and looked at cases in the VA from 1995 to 2012. And the cases, and I'll show you in a minute what they look like, but the cases increased over that period of time each year. The number of women who were Black who had breast cancer during that time increased from 16% to 25%, but we don't know if that's because, well, we know women that are Black may have more, may have higher incidence of breast cancer anyway, but it may be just because there were more women of color in the sample. The median age actually went down. So, people were being diagnosed earlier. And I think the most positive thing about this work is that the node negative, and the node negative, as I understand it, means that after, from your breast cancer lesion or your tumor, they go to the first lymph node and they test that lymph node. And if that lymph node has cancer, then they go to the next lymph node. But so the node negativity went from 45%, which is less than half, to 64%, which means they were catching the cancer earlier before it can metastasize. The other good part of that we know is that women between 40 and 49, and you know, Dr. Richmond can talk about when you should have your screening, but 76% of women veterans served in the VA in that age group got their screening, and 86% of the higher risk group of 50 to 74-year-olds were screened. We don't know necessarily the results of those, but the fact that they get screened means that they're going to get treated earlier. You can go to the next slide, Marissa. So this kind of shows the number of cases going up, but what we don't know is the number of people in the, whether the number of women in the military was also going up during that period. But we know the greatest increase in the number of women in the military came after 9/11. So, you know, we could see some of that. I have no idea what happened to 2011, but it's kind of interesting. So let's go to the next slide, please. So Marianne's going to talk about other, you know, issues that address whether your risk for breast cancer. But I thought that some lifestyle type issues that people sometimes don't consider when we talk about breast cancer were really important to consider when we talk about women who are veterans. So these are the things that we know have a high correlation. They don't necessarily cause breast cancer. We can't say that they cause breast cancer, but they're seen frequently in women that have breast cancer. So high stress levels. I'm sure that you all could tell me more about stress for women who are women veterans or women who've worked in the military than I would know. People that work at night or who have rotating shifts, which causes sleep deprivation. We know that those folks whose circadian rhythm gets out of whack are more likely to have breast cancer. Women who live or who have been subjected to severe heat, particularly for long periods of time, are more likely to have breast cancer. Women who have delayed pregnancies, who either wait to have a pregnancy or are never pregnant, have a high risk factor. Being pregnant, or actually not being pregnant, having a pregnancy that comes to full term, having a baby, and or breastfeeding a baby come from are protective factors for breast cancer. We see less breast cancer in women who've had children than women who have not. Alcohol use is another high incidence or high correlation to women have breast cancer, particularly those with high alcohol use. And finally, the one that we might all think of is that environmental pollutants are definitely highly correlated to breast cancer. And a study showed that women who in the Army who handled volatile organic compounds, I don't know what those are, but they don't sound good to me. They had a 48% higher incidence of breast cancer than other women had. So, you know, yes, does this mean that if you're a woman veteran, you're going to get breast cancer? No, not at all. But what it does mean is that you're at greater risk, and you should probably be managing that risk and trying to, and assuring that you're getting screened and being careful about that. Go to the next slide, please. So women living with mobility impairments, we know that they are less likely to have screenings, about 10% less than women in the general population. Why? Centers for Disease Control have done a lot of qualitative work with women, and the reasons that they come up with are that hassle factor, that getting undressed, you know, having to depend on someone moving their body who they don't know and who might not know about what some of their limitations are, their access to screening clinics, to the equipment, which is changing significantly over the last few years, to the changing rooms, to the staff. I think all of these things are improving, but if you had a bad experience once, your likelihood to think about doing it again is probably less. And then just the basic issues that women who have mobility impairments live with, the inability, transportation, inability to get to the clinic where they need to have the care, and what in my world we call reimbursement is basically who's going to pay for it. And certainly Medicare pays for insurance, but women that are not military veterans don't have access to the same kinds of health care and may have difficulty in actually accessing those things. So next slide. So it's really not about parent wearing pink. I don't think that has any impact. It's not about thinking about this only in October, which is Breast Cancer Awareness Month. It's not about saving the tatas. You know, those are big issues, but it's really about saving your life. And so I'm really pleased that we have Rhonda Barber here from GE Healthcare, who can talk with you about what a mammogram is and what kinds of care you can get or you need to get in looking at this. Thank you.
Thank you very much, Cheryl, and thank you for all the participants that have joined. So when we think about a mammogram, you know, every patient that has a mammogram, we're only looking for one thing, and that really could change their lives. Mammography is the only modality that has a primary focus on a single disease, which is breast cancer. Next slide. So we know from the American Cancer Society, 1 in 8 women will develop, you know, breast cancer in their lifetime. Shockingly, only about 73% of the women surveyed that have said they've had their mammogram in the last year, 2 years. To be real honest, 50% of the American population, women, are not reporting having a mammogram. They're not coming in to have their mammogram. So we really need to make sure that, you know, we are educating as friends, you know, our women friends, to let them know that we really need to have that mammogram, just as Cheryl had mentioned regarding her friend. So in 2020, just to give a few statistics from the American Cancer Society, 297,000 women will have new diagnosis of breast cancer, with 42,000, roughly 43,000 deaths. As Cheryl had mentioned, this is also not just something that affects women, but also men. So there'll be about 2,700 men who will be diagnosed in 2020 with breast cancer, with about 520 deaths. And Dr. Richmond will speak to some of all of this a little bit later as well. Next slide. So right now we're going to open a polling question. We just kind of like to understand the terms that I'm going to be talking about, or even Dr. Richmond is going to be speaking to. Are you familiar with some of these terms? So you can just answer yes to 1 or more, or 4 or more, or no. So the terms are mammography, early detection, dense breast tissue, risk factors, guidelines, screening, diagnostic, breast MRI, and ultrasound. So if you'd like to answer those questions. And we'll give you a few minutes so everyone can do that. So great, looks like most people know 4 or more of these terms, which is wonderful that you are familiar with this terminology. Next slide. So what is a screening mammogram? A screening mammogram is really looking for signs or symptoms or signs of breast cancer within the breast. It's an X-ray that is done yearly, or depending on your physician and what you have made that determination. And typically there are no symptoms within the breast. It's not like you're feeling a lump, or the doctor has felt something, or you have a change within the breast appearance. So no signs or symptoms. It's a screening mammogram. The goal is, as I had mentioned in the very first slide, is to look for a possible early breast cancer. We want to be able to find that at the smallest possible size. And, you know, we know the smaller the cancer, the more successful the treatment. The screening mammogram usually consists of 2 views of each breast, and more views may be obtained depending on the size of the breast, or, you know, just the composition of the breast. Next slide. So what I'm showing you here would be the traditional screening mammogram. The top views are the CC views, or the craniocaudad. It's just how the projection is going from the head to the feet, that X-ray beam. Or the other is the medial lateral oblique, which is also looking at that breast tissue as well, going from a side view. Next slide. So those images that I showed you in the prior slide was really like 2D imaging. If you look to the kind of description illustration where it says 2D image, and right below you kind of have kind of lines and dots. With 2D imaging, what that is that you are really seeing from top to bottom. You're not really being able to see through the entire tissue through what we call slices. So most recently, breast tomosynthesis, DBT, or 3D mammography has been introduced. And what that does is it takes a sweep of the breast, and it is allowing the radiologist to see multiple planes of the breast. So you are pulling that, potential overlapping into each particular slice. We'll go to the next slide. And what I'm going to show you here is kind of that slide to the left, or picture to the left, is the volume preview. And then the image to the right is actually a tomosynthesis image. You can see it's kind of doing a cine loop through. But if we come back and kind of look halfway in between, about a little bit further ahead, what you'll see is back towards what we call the chest wall. Can we go back? Okay. Back towards the chest wall, you can see a difference in appearance that you don't really appreciate in the image to the left. So the advantage of tomosynthesis is allowing you to see through multiple planes, or that radiologist to see through multiple planes. It'd be like if you had bread and you put it together, but then you made slices. Depending what's in the middle of that bread, you wouldn't really see it as you look at it as a whole, but you would see it if you sliced that bread. Next slide. So the other important thing to understand is your breast density. We know that mammography is the gold standard for evaluating for breast cancer, but we also know that there are women that have denser breast tissue, and mammography alone is not allowing us to see everything within the breast. So you may be asked to have maybe a breast ultrasound, whole breast ultrasound. If you do fit into that heterogeneously dense, that C or that D category, you will receive, after you have your mammogram, what they call a lay letter. And in that lay letter, it may say at the top you have a normal mammogram, but it may tell you later in that letter that, you know, you do have dense breast tissue and you need to have additional imaging. Next slide. So this is just an example of, you know, to the left are two different patients. One that is more of a fatty tissue where you can kind of see through everything. If you look at the one that's kind of to the right, we call this a snowball and snowstorm. You know, that breast tissue is very dense. It's a challenge for that radiologist to kind of see through everything. As tomo does help, we also know that having ultrasound can also be a benefit for that patient. So the illustration to the right is showing you that this patient had an automated breast ultrasound. There is kind of that hole, you can kind of see where they're pointing to. And this is also an ultrasound image that's directly below, and you can see that there is a lesion in that space, where on mammo alone, we may not have necessarily seen that. So the benefit of having that adjunct to mammography. Next slide. So what are some of the signs that you may see apparently on your breast and what to look for? You may feel a lump. You may have, you know, a pulled in the nipple. You may have dimpling in the skin. You could have some discharge from the breast. You could have some redness, or you could have a skin rash. These are signs or symptoms you need to look for as you're doing your breast self-exam to make sure that, you know, you're not seeing any of this, and consult your physician. Next slide. So why is a diagnostic mammogram performed? Well, say that you have that screening mammogram and there are findings. They may ask for additional views just to be done a little bit differently, say spot compression, magnification. And it's allowing that radiologist to be able to see that region of interest just a little bit differently than on a screening mammogram. But you could present for a diagnostic mammogram if you're feeling a lump, or your physician felt the lump, or those signs that I described earlier in the previous slide. You would present for that diagnostic mammogram, and in that case, they may do that routine 4-view study to take a look. And usually when you are in for a diagnostic mammogram, it's almost always read immediately by a physician, so you kind of know your next steps. Next slide. So what are some of the names of primary breast cancer? You have breast cancer can be non-invasive or it can be invasive. You have ductal carcinoma in situ or DCIS, invasive breast cancer, invasive ductal breast cancer, invasive lobular breast cancer, inflammatory breast cancer, or Paget's disease of the breast. So some terminology, just so you are aware, hope that you do not have to be part of a discussion, but just so you know, there are different types of breast cancer. So as I'm with GE, we are offering all the modalities out there. And so the image kind of here is showing a mammography unit itself, actually with a biopsy attached. We have a design that we call patient-assisted compression, which is allowing the patient to be actively involved with that compression. In the center, you're going to see a handheld ultrasound system. To the right of that is an MRI system. And then I had spoke about the automated breast ultrasound, which is to the complete right. And then we have molecular breast imaging. But what you're typically going to see is a mammography gantry, and you may see, ultrasound or automated breast ultrasound, depending on the facility that you go to, that would be part of that follow-up for you. Next slide. So let's talk about the woman veteran in the VA. So unique healthcare needs for women in the VA. We know that the population of the woman veteran is growing, and within the next 20 years, it will double. So we need to meet the needs for the woman in the VA to get those women's health needs. Over 500,000 women use the VA for healthcare, and the VA is actually the largest provider of oncology services in the US. Next slide. So let's just make some data point comparisons with breast cancer and the woman veteran. In 2017, 65% of invasive breast cancers were diagnosed, and that was with that woman of the age between 40 to 69. According to VetPop in 2018, 60% of women veterans are between the age of 40 and 69. So very important to, have that annual mammogram as that age range for the veteran is very close to the average population. The incidence of breast cancer are higher among non-Hispanic white and non-Hispanic Black women than Asian and Pacific Islander women. So in the VA, non-Hispanic white women and Black or African American women make up over 1.6 million of the nation's 2 million women veterans. So very important, no matter who you are, you need to go in and get your mammogram. So at this time, I'd like to pass off to Dr. Richmond at the VA in Cleveland. And as my last slide, I just want to remind you, please do not skip. Please get your mammogram. Does not have to be done in October. It can be done any day, any month. So thank you.
Good afternoon. Can you hear me okay?
Yes.
Yes,
Fabulous. Fabulous. Sorry about that. I know my camera's not working, but anyhow, welcome everybody. I'd like to go ahead and just talk a little bit about breast cancer itself. Uh, Breast cancer is the most common diagnosed cancer in women, and it's the second leading cause of cancer death. Lung is first. I just want to remind that lung is first. So if you are a smoker, please see your primary care provider, spinal cord injury provider, about how we can help you quit smoking. I just had to put that out there because lung still remains our first cause of death amongst cancer deaths. So how much breast cancer do we have a year? We have over 250,000 cases a year in the United States. That's no small number, with 42,000 deaths per year in the United States. Next slide, please.
We have a poll question that we'd like to launch. So the question is, have you had a mammogram in the past year? You can select yes or no, and we'll just give everyone a few seconds to get that answer. All right, thank you. And here are the results. Looks like most of you have. Thank you.
Very nice, very nice. Great response. Thank you for those who answered the poll. So let's move on to the risk factors associated with breast cancer. They're broken down into things that you could modify and those that are not, the things you can't modify. So let's talk about the modifiable risk factors first. Hormone use. Hormone use is a known risk factor for breast cancer. Many are on hormones for a variety of reasons, but you should be aware of that risk tied to breast cancer. Being overweight or obese is a risk factor for breast cancer. Alcohol use and smoking. Those two things especially you can modify. So the non-modifiable risk factors for breast cancer would be dense breasts, a first-degree relative with a history of breast cancer, history of benign breast biopsy, being less than 45 years of age and African American, Caucasian, estrogen exposure in the past, nulliparous, not having children, and chest radiation. I want to just spend a moment about family history. That's really, really important. If you know a sibling of yours, a sister of yours gets diagnosed with breast cancer, that you talk with your provider about it, especially if they were diagnosed at a young age. Family history evolves over time. So please keep your provider aware if you do have family members, first-degree relatives who do develop breast cancer. Next slide, please. I like this image. This image shows a woman in a wheelchair with spinal cord injury obtaining a mammogram. This is to instill that, yes, you can get a mammogram if you have any physical impairments or any barriers. They can accommodate. I just want everyone on the call to know that you can get a mammogram from a wheelchair. Just so that you know that. Next slide, please. Okay, so this is the heart of what I want to talk about. Screening. In the VA system of care, we use the American Cancer Society guidelines. I want to let you know there are lots of guidelines, and I encourage you to go to the CDC website and look at the variety of guidelines. You know, institutions adopt guidelines, and I think it was when Dr. Shulkins was in charge in about 2017, made the switch to us using the American Cancer Society. So your neighbor may have something a little bit different. So again, the CDC has if you go to the CDC website and you just say mammogram screening, you can get this wonderful document that shows all the different types of guidelines. So the American Cancer Society. So when you start age 40 to 44. During that period of time, it's a shared decision. You talk with your PCP, your women's health provider, your spinal cord injury provider about the risks and benefits of having mammogram. The American Cancer Society does not put a hard yes, you must have it. They want you to explore the benefits and risks with it. And so it's an individual decision. Age 45, that's really when it starts for sure. And again, it could start early, so that's fine as well. But there's a strong recommendation for screening yearly for breast cancer. How often is it? Starting at age 45 to 54, it's annual. Now, when you are 55 and beyond, again, this is where it can go either way. It can continue annual, which means yearly, or it can go to every 2 years. Again, that's a conversation you would have with your primary care provider, your women's health provider, or your spinal cord injury provider or other providers. So when do you stop? When does mammography screening stop? Well, this varies. What they do want you to have is a good life expectancy of greater than 10 years. So you could be well into your 70s or beyond and continue with screening if your life expectancy is greater than 10 years. And for the average American woman, it's about age 80. So next slide, please. So that screening process is for average risk women. Risks in high risk. And what we mean by high risk, that's a personal history of ovarian, peritoneal, tubal, or you have a genetic position such as the BRCA, BRCA, or other susceptibility genes. You had prior radiotherapy to the chest between the age 10 and 30, and you have other breast cancer risk factors, such as a strong family history. You move into a different category. This is where you will work with a specialist, and maybe even somebody who specializes in genetics. It's a team to look at your high risk for screening. It's likely very much different than a mammogram, and it'll entail different steps. I'm not going to go through those steps today, but just so you know, if you are high risk, you should be seeing a specialist about the steps you should be doing for screening. It's much different. Next slide, please. So who do you contact? You might already be in with your primary care provider, spinal cord injury team member, or women's health team that they are reminding you of this. So please continue to follow with them. If by chance you are not tied in with somebody, the first provider to talk to would be who you define as your primary care, or in the VA system we call PACT provider. They would be the ones to help facilitate getting a mammogram. If those who are spinal cord injury, your spinal cord injury team, whether you're at the spoke or the hub, which is the center, and of course some women veterans are already tied in quite nicely with women's health, so you would want to start with them. Okay, next slide, please. So what are the next steps? The next steps are, again, as we spoke to, talk to your provider. Get a mammogram if it's recommended, or it's a joint decision, shared decision. So when you set up that appointment, it's okay to talk to them about what your needs are. We say that for all women, whatever concerns you have, address it then. I would let them know that you'll be needed to be a mammogram from a wheelchair. Those are things you'll want to share so they can be prepared and you can feel comfortable. And if there's any questions you have, please ask questions to those that are delivering the care to you. And additionally, after the results come back. If by chance you have any barriers, concerns, they're not meeting your needs, or you're uncomfortable, please let us know. You can talk with your women's health coordinator at your VA. You can talk with your primary care. We have a national program office of women's health that would be very interested in knowing if you had difficulties. And of course, your VSO, like the PVA, are always here to help you if you're not getting your needs met. I will put something out there. Accessibility. Those places that deliver mammography services need to be accessible. We need to hear, it shouldn't happen, but if it could, if it's inaccessible or you're having difficulties, we would like to hear about that. But the final point is, please get your mammogram. Next slide, please. Okay.
Thank you,
So
Dr. Richmond.
I will let the
so much.
moderator take over. Thank you.
Yes, thank you. So now we can begin to address some of the questions. So we got some questions submitted before in registration, as well as a couple questions during the presentation. So if you do have questions, now is a great time to put them in the Q&A box. The first question that we can address is, as a female with SCID, we need x-rays for our chest areas more frequently. Does this increase our risk? Dr. Richmond, do you want to address that question? Sure.
So I'm going to take a step back. I always get this question about, oh, the radiation, if this is what, the radiation from getting a mammogram, I'm worried about that. It's very small amount. It's very important that you know that radiation you get from, if this is the question, from having a mammogram is very small. You could probably calculate exposure that you normally would get for just being out in the community. It's a very small amount of exposure. And there's no risks from having, like, there's not a risk of developing cancer from getting screening for breast cancer. So does that answer your question? And in regards to spinal cord injury women themselves, I don't see any higher risk is that what the question was, or did I miss it completely?
No, I think you got it. So then the next question we have, let me see. So this one is about mammography. If the machines are only accessible enough to capture 30 to 40% of breast tissue, what other form of screening should we use? And I think we covered this a little bit, but we can, of course, cover it again.
So,
Rhonda or Dr. Richmond?
So this happens, sure, this happens, and I'll let others speak. This happens for all women, that sometimes you're screening, you'll come back for other views, or for a variety of reasons, they can't get that best view for you for somebody has a broken shoulder or something else. There's many reasons why women in general sometimes don't get complete mammograms. What the radiologist will do is make a decision on the next step, and that varies. So the radiologist might bring you in for ultrasound. They may reattempt views. You might have to come back again for another trial of it. But their goal is to get complete visualization of the breast tissue. However, for all women, sometimes it doesn't work out. The radiologist will determine what the next step will be.
Thank you, Dr. Richmond.
Did that answer it?
Yes, thank you. So the next question we have, someone asked, is there another way to examine healthy tissue of a woman's breast other than using a machine? They asked, is there a blood test that is possible?
Yeah, that's a fabulous question. I thought you might speak to breast exams, whether done by the patient themselves or by a provider. That has fallen somewhat out of disfavor because, you know, for a variety of reasons. But obviously, if you develop a finding on your breast that you notice and you go in to see your provider, the first thing they're probably going to do is a breast exam to confirm it. You are no longer in screening. You're in a diagnostic mode. They're going to be searching to why you have a lump. But for screening itself, the gold standard, and really the only standard right now, is mammography. There are the use of other modalities, again, more for the higher risk patients, such as breast MRI. My understanding of breast MRI is you have to be on your tummy. You're on you're prone. That is not the standard right now, breast MRI. And then there's of course ultrasound. Again, that's usually a diagnostic tool where you're trying to figure out something they saw on the mammogram, but there is no blood test. Now, if you are in high risk, there are, like we talked about, a woman who is carrying certain genes, the geneticist and that team of specialists might be doing blood tests. But again, you're not really in screening, you're in a high risk category. But so in summary, there is no blood test for screening for average risk women for breast cancer.
Thank you. And this next question can be for Dr. Richmond or for Rhonda. What are some recent innovations in breast health examinations that reduce the discomfort of the exam?
We'll let others, I'll let the other team members take that one.
Yeah, so obviously I work for a vendor. So there's different gantries, different manufacturers, and what they do, and they're designed to make it more comfortable for a patient. One of our designs is having more rounded corner, a thinner detector. So it's less uncomfortable for that patient depending on their body habitus. The Duetta, which I described, which is patient-assisted compression. And now not every facility would have this, but just to let you know that, this is something we have done, which putting that patient in control of some of that compression. Obviously, your technologist is still going to position your breast, is going to apply that compression. Another vendor has what they call a smart curve paddle. Our thought was we need to design the entire system to be at more comfort to that patient. But not everyone is going to have maybe our equipment in their facility, but you can ask what their facility has as equipment and that comfort that they have for the patient during the exam.
Thank you, Rhonda. And then you talked about this in the presentation, but if we could go back to what role does density play in risk factor?
So there are different studies that say that with dense breast tissue, you are at a higher risk factor. That's why studies have been done to show that, as mammography is the gold standard, like Dr. Richmond had said, there is that population that needs to have that additional imaging with ultrasound. Even if your screening mammogram is negative, it is going to move you on to a screening breast ultrasound because of your breast density to help look for that breast cancer as well.
Marissa, could we go back to the X-ray question? I think that the question was not, does the X-ray with mammography put someone at greater risk? But the question was, if you live with a spinal cord injury, particularly a high spinal cord injury, you've had pneumonia, those kinds of things, you're probably getting frequent chest X-rays. And so do those frequent chest X-rays, do those present a risk factor for breast cancer in women?
Marianne here. I get the question. Thank you. No, they don't. We have seen, they're talking about the between 10 and 30. That's big amount of radiation for treatment of cancers or other reasons why their chest is being radiated. That's it's more of a procedural therapeutic reason for it. When you're doing diagnostic, which is checking for pneumonias, people get frequent chest x-rays, and over time, we like to limit it, of course, and we never want to do anything that's unnecessary. But there's no good studies showing that, over your lifetime, if you had 50 or 100 chest x-rays, your risk is higher. The radiation doses, again, they're referring to are more on the therapeutic, and at a certain age period, that puts you at risk. So if you need that chest x-ray, please do get it.
Okay, thank you. I think that answered the question better. So does anyone else have any questions? Please feel free to use the Q&A box. If not, we'll start wrapping up. Thank you. So again, just thank you to our speakers. That was such an informative session. And if you need to go back and watch any of it again, as I said earlier, the webinar today was recorded. So all attendees will receive a link to access it as well as the slides. So you can go back and review any information that you'd like. I also want to make sure everyone on here knows that in November, we are having a 2-day virtual seminar with informative sessions as well as networking opportunities with other women veterans. If you're not already registered, please use the link that is on this slide to do so. All right, and I don't see any more questions in the Q&A box. So with that, thank you everyone so much for attending today. I hope you have a great day. Thank you.
Thank you.
Thanks, Mary Ann. Thanks, Rhonda.